Ladies and gentlemen, for the successfulness of the operation, we need to have a pre-operative evaluation of the neck, particularly for metastatic lymphadenopathy. So this is the diagram. We can see if we know the metastatic lymphadenopathy, we can have the surgeon explore the reason and do his procedure properly. For the total operations, we need to know every single lymph node to reduce the recurrence rate. The number and location of the lymph nodes important for deciding the next decisions place. So, for the thyroid cancer, we can have a different approach. So maybe it's very small and sometimes it's very big and long. So it depends on the number and location of lymphadenopathy. So therefore, ultrasound should be used to map the lymphadenopathy before doing surgery. We use ultrasound to evaluate the primary tumor expansion and also the lymphadenopathy. And some meta-analysis tell us that the ultrasounds can change the surgical approach in about 40% of cases. Sometimes we plan to have a large incision, and after ultrasounds, the patient will receive very small incision. The question is why we need to do ultrasound to map the lymphadenopathy. How can we do that and what's the results? So why should we map the lymphadenopathy before doing surgery? There are so many discussions between society. There are different recommendations. This is the European Society of Endocrine Surgeons. They suggest in tumor grade T3 or T4, and the patient is more than 45 years old, have evidence of lateral lymphadenopathy metastasis, then we need to expand the incisions. Some other have a different guideline. And then a lot of society suggests that the a large lymphadenopathy and have evidence of metastasis, and then we will extend and expand the incision area, surgery field. So there is an important thing is to find the evidence of the cancer is expanding to give the surgeon decides where and what to do surgery. However, ultrasound sensitivity is quite low in the central neck, ranging from 30 to 87%. That's in front of the tracheal and adjacent to tracheal. It's very difficult to detect. However, it's very important and we need to be removed when doing surgery. Because of the low sensitivity, so type of thyroid cancer, if we do proper ultrasound, we even get 100% of sensitivity and specificity. Some other suggestion in Canada for papillary thyroid cancer, ultrasound can give the true positive rate about more than 80%, even in the lateral or central compartment. So where is the lateral and where the central compartment? The central space, these areas cover the tissue surrounding the trachea. And the lateral space, that's around the carotid bundle. And the posterior, we have another four space. So we can see on the diagram the central compartment is that around the trachea. So lateral space around the carotid bundle. Before knowing the abnormal lymph node, we need to know how normal it is. It's quite difficult to see the normal and abnormal structure because the normal structure here we can see have the hilar and have a regular margin. In some critical cases, if the lymph node is small, it's hard to see the normal structure. The malignant finding, the size more than 5 or more than 10 millimeters. Because the ultrasound sensitivity in the central space quite low, so therefore if we see the lymphadenopathy about 5 millimeter is already positive. round shapes, also the suggestions of malignant. Hypervascularity is also the malignant finding. Calcification and also irregular margins also the finding for malignant pathology. Here is the illustration. You can have the oval shape. However, the height is quite long. We have a microcalcification. You can see the low echogenicity in a lymphadenopathy is highly suspicious of a metastatic lymph node. However, in practice, it's very difficult to find the lymph node like this. In Doppler ultrasound, it's not a important initial. This is the necrotic lymph node, more likely to be a malignant one. Another question is so how the lymphadenopathy mapping affect the surgery. How can you create the lymphadenopathy map? It may be very easy to create the diagram on the report. We have to measure where's the thyroid, and we have to draw the carotid. So the results must be in combination between clinicians and ultrasound doctor. We need to have discussed before and after doing ultrasound. For some specialized surgeon, if you don't have a lymphadenopathy mapping, they won't do the surgery. However, in Vietnam, sometimes the surgeon may not need the mapping, but actually this is very necessary. So the finding is maybe the short axis, and also calcification margin is the major finding to differentiate between benign and malignant. Here is our study. Before surgery, we have only seven cases have a central lymphadenopathy, but actually that lymphadenopathy are malignant in the posterior in the post-surgery pathology. The lateral space is not difficult to use ultrasound, so we can easy to map the lymph node. Here is the typical case. We have the patient have a nodules in the superior pole of the thyroid. On ultrasound, there's no lymphadenopathy. However, did the ultrasound when patient underwent surgery, we have the tumor as ultrasound, but still have some small lymphadenopathy in group 6. And the other case, superior left nodule and the neck lymphadenopathy was missed on ultrasound, but actually they found it on surgery. This patient have a bilateral thyroid tumor. This patient have the lymphadenopathy in the lateral space in group 4 and have the tumor with thyroid 5. Here is the carotid. You can see the carotid veins, jugular veins in the front. So from carotid going laterally, it's the lateral space. There's the different case with the lymphadenopathy in the group 3, and we see it look like a malignant appearance of the tumor, and the pathology is metastatic lymphadenopathy. This is the lymphadenopathy located laterally to the carotid artery. This is a typical of the metastatic lymphadenopathy. And here is the big lymphadenopathy outside the carotid space, and it's very relevant to the pathology after surgery. For clinical application, mapping the lymphadenopathy using ultrasound is a valuable tool to define the metastatic lymphadenopathy with quite high positive value, proportion value.
đánh dấu tức là bản đồ hạch đấy, lập cái bản đồ hạch trước khi phẫu thuật là một cái phương pháp rất là tốt.
So pre-surgery mapping at the lymphadenopathy is very useful, not only for surgeon but also for the patients.
Và cái đó thì nó không phải là một cái phương pháp mà mang tính chất là duy trí, mà dựa trên những bằng chứng khác nhau thì người ta thấy rằng là đấy là một cái phương pháp mà có thể tin cậy được, đặc biệt là trong cái trường hợp mà ung thư tuyến giáp vú chiếm.
And that is evident particularly in patients with papillary carcinoma.
Tóm lại là như thế này, chúng ta nên lưu ý rằng là hạch trong di căn tuyến giáp
Take home message.
chia ra hai khoang.
We have two compartments.
Khoang trung tâm và cái khoang thứ hai là cái khoang bên. Và hạch được coi như là hạch mà nghi ngờ ác tính khi mà nó thay đổi cái kích thước, thay đổi hình thái, mất đi cái cấu trúc.
The lymph node is more likely to be a malignant when the size is larger than 5 mm in the central and 10 mm in the lateral space. The round shape, loss of higher echogenicity, and also microcalcification.
Cái cách thức mà chúng ta triển khai thì là mỗi chúng ta có thể là đơn giản hóa cái vấn đề nó khác nhau.
This is the way to report.
Rất là dài dòng ở trên giấy thì là chúng ta có thể vẽ ra các hình ảnh. Trong hình ảnh đó thì nó chỉ cần là lưu ý hai điểm. Điểm thứ nhất là cái mối tương quan với cái tuyến giáp, và cái thứ hai là cái mối tương quan nó với cả cái động mạch cảnh ở hai bên. Và với cái đó thì là chúng ta sẽ rất là dễ dàng vẽ được. Tuy nhiên là hiện nay với xu hướng phát triển của bệnh án số hóa cũng như là để có cái data lớn để chúng ta gom lại và phân tích về sau này, thì cái chuyện vẽ đấy nó lại gây ra khó khăn trong cái vấn đề mà số hóa các cái data. Nếu như mà bằng các cái phần text thì là chúng ta số hóa rất là dễ, ví dụ như là nhóm 3, nhóm 4, nhóm 5 hoặc